Good afternoon. Thanks for joining us. We're going to have a discussion today about heart failure, what causes heart failure, how we treat it, and about some of the successes that we've had over the last few years and some of the future directions we hope to turn to make more of a success in the future. So our goals for the talk today are to talk about the prevalence and prognosis of heart failure and to learn how we can improve outcomes for our patients. So a few facts to begin with. This is a widespread disease in the United States. A little over 6 million adults in the U.S. have a current diagnosis of heart failure. In 2018, 13% of death certificates mentioned heart failure as a cause of death. It's responsible for almost 1 million hospitalizations per year and over 1 million emergency room visits for heart failure annually. By some estimates, it's the most common diagnosis for admission for patients over the age of 65. The costs to the nation are estimated at over $30 billion in 2012. Of course, that includes the cost of their hospitalizations, their medications, and their missed days of work. And in general, with heart failure with reduced ejection fraction, which is primarily what we're going to talk about today, the 5-year mortality rate is daunting at almost 50%. So just to show you that we're not exempt to heart failure, this is a map that's published by the CDC every couple of years and updated by them on a county basis. It shows you the mortality rate for heart failure. And you can see that the darker red squares are the highest quintile of death rates. And here in Titus, we're square in the middle of one of those, as are our surrounding areas. So this is a diagnosis that has a great deal of penetration in our area and a great deal of associated deaths on an annual basis. There are different ways we can classify heart failure. First of all, we can do it on the basis of what the patient's systolic ejection fraction is of the left ventricle. We generally refer to heart failure with reduced ejection fraction at those people having an ejection fraction of less than 40%, and those people having heart failure with preserved ejection fraction at greater than 50%, although the earlier studies have included patients in the 40 to 49% ejection fraction range as well. We also can classify it on the basis of time course, so patients who present with sudden onset of heart failure symptoms or worsening of previous symptoms, we consider acute heart failure, whereas those who have had symptoms present for more than 3 months, we consider chronic heart failure. And finally, we can classify it on the basis of the level of symptoms, and for this we use a scale that was developed by the New York Heart Association, so that Class 1 heart failure patients are generally those that have no real limitation to their daily physical activity. At the other extreme, we have Class 4, where they're unable to do virtually any physical activity without having symptoms, and in fact even have symptoms of heart failure at rest. Classically, what you're going to see in the hospital are primarily those with Class 3 and Class 4 heart failure, because those are the people who have severe enough symptoms that they warrant hospitalization. There are many causes of heart failure, and this is only a partial list, but the point is that there are many different ways we get to this endpoint of heart failure. The most common ones we see are coronary artery disease, in which case we have permanent damage in many cases to the heart muscle from previous heart attacks, either recognized or unrecognized. Hypertension, which can cause changes in the heart muscle, stress on the heart muscle that can cause, first of all, heart failure with preserved ejection fraction, and over time can actually cause damage to the heart muscle with dilatation of the heart, and heart failure with reduced ejection fraction as well. There are idiopathic cardiomyopathies, which is a fancy way of saying we're not really sure why they have it, but they have it. And most common within this category would be previous viral illnesses that were unrecognized that may have attacked the heart muscle and weakened it. And then we have less common things like certain arrhythmias, for example. Long-term tachycardias can cause weakening of the heart muscle through tachycardia-mediated cardiomyopathy. We can have endocrine disorders like hypothyroidism that can affect the heart muscle directly. We can have unrecognized myocarditis. We can have an entity known as postpartum cardiomyopathy in younger women after they deliver their child that can cause severe weakening of the heart and severe cardiomyopathy associated with symptoms. There are restrictive cardiomyopathies, which are so-called because there's deposition of material inside the heart muscle in between the muscle fibers, and it prevents the heart from performing adequately. And then further on down the list, you'll see other diagnoses that are typically more associated with heart failure with preserved ejection fraction, things that can cause volume overload, such as excessive salt or water intake, certain medications, and those sorts of problems. I also will point out in the factors above toxic cardiomyopathies, which we see a fair amount of here in our area, either from previous radiation to the chest because of cancer treatment, or in many cases because of alcohol or cocaine use as well. So we now recognize these days that there are four main pillars of treatment of heart failure. And again, I'm going to talk primarily about heart failure with reduced ejection fraction, those with ejection fractions of less than 40%. But much of what I say can be applicable to other groups as well. And I'm going to go through these four pillars, and we're going to talk a little bit about how the mechanism of action occurs with each of these types of therapeutic interventions. So the first type of agent that was shown to have benefit in heart failure patients were the ACE inhibitors. So you'll remember from your basic pharmacology and physiology that the liver makes a protein called angiotensinogen, which is converted by release of another molecule from the kidney called renin into a precursor molecule called angiotensin 1. Angiotensin 1 is then turned into angiotensin 2 by another molecule that's secreted primarily by the lung, which is called angiotensin-converting enzyme. And angiotensin 2 is the active molecule that causes lots of effects in our body. First of all, it increases sympathetic activity, so it makes the heart work harder. It also has direct effects on the kidney to cause the kidney to reabsorb sodium and water to increase the volume of the body. It works directly on the adrenal glands to cause release of aldosterone, which is another hormone that also acts on the kidney to cause it to retain more sodium and water and keep those in our body. It has a direct effect on small arterioles within our body to cause vasoconstriction, so it increases our blood pressures. And it works directly on the pituitary gland as well to cause release of antidiuretic hormone, which is another molecule that will cause the kidney to retain extra water. So all of those are effects which will make someone who's already volume overloaded even more volume overloaded. So angiotensin-converting enzyme inhibitors will block that step where you have the activation of angiotensin 1 to angiotensin 2, and by doing so can prevent conversion to the active molecule that causes all of those effects which make heart failure worse, and that's its mode of action. A related type of drug that was developed several years later is called an angiotensin receptor blocker. It doesn't prevent the development of angiotensin 2, but it blocks the receptors that angiotensin 2 binds to in all of these other end organs. So it has a similar type action. So we refer to the angiotensin-converting enzyme inhibitors as ACE inhibitors and the angiotensin receptor blockers as ARBs, ARB. Second type of agent that became popular to use several years later were beta blockers. And you think about myocardial injury, when you have a weakened heart muscle, you have decreased contractility, decreased peripheral perfusion. Well, the body's reaction to that is to have activation of the sympathetic system to try to compensate. When it does that, it releases large amounts of catecholamines, and these catecholamines can actually cause a vicious cycle that makes things worse. So when you release lots of catecholamines, the first thing that happens is you actually get a desensitization or downregulation of the beta-adrenergic receptors on cells. So the sympathetic discharge causes less responsive to future sympathetic discharges. The second thing is it can cause further myocyte damage, and it can cause premature death of heart muscle cells. In addition, it can cause certain arrhythmias. Now, the beta blockers work by blocking this sympathetic activation. And so all of those effects can be blocked by the use of beta blockers. And intuitively, you would think, gee, you wouldn't want to give somebody a beta blocker when their heart's already failing because you're going to make their contractility worse. But the fact is, by blocking this sympathetic activation, you interrupt that vicious cycle and you allow the heart to recover. And there have been multiple studies with multiple different beta blockers that have shown as a result of this that in class 4 patients who can barely be active at all without symptoms, that by treating them with various beta blockers, you can markedly decrease their risk of mortality. The next set of agents that came along are the ARNI agents, which are a combination of an angiotensin receptor blocker with another molecule called a neprilysin inhibitor. Excuse me. So we release in our bodies proteins, which are called natriuretic peptides. They're proteins that are released by various organs, including the heart and the brain. And these natriuretic peptides cause us to actually create a diuresis within our body. They're an internal diuretic that our body actually makes that causes us to excrete sodium and water from our body when we don't need it. These are broken down by a series of enzymes. One of the most important ones is neprilysin. And this inhibitor blocks that breakdown of these natriuretic peptides so they can remain active and cause better diuresis in our body. So Entresto is the only currently available form of this medication. So it's a brand name agent and relatively expensive, but it has superiority to treating with either an ARB or an ACE inhibitor alone because it also has the additional benefit of the neprilysin inhibition. And because of that, it's generally recommended that we try to switch patients over time from an ACE or an ARB to one of these agents. However, because it is a brand name agent, it is quite expensive, and some patients won't have adequate insurance coverage, and some patients can't afford the out-of-pocket cost of doing this. And as a result, although it's a desired drug to use, it's used less frequently than the other drugs we're going to talk about today because of those reasons. The next set of agents that are used are the mineralocorticoid antagonists. Now, you remember we talked about one of the effects of angiotensin 2 was to stimulate the adrenal gland to release more aldosterone. Aldosterone acts on the renal tubules to cause them to resorb sodium and water and to excrete potassium. So the aldosterone inhibitors like spironolactone work by blocking that action of aldosterone. And by doing so, they can prevent the kidney from reabsorbing a lot of sodium and water and allow them to excrete that out of our body instead. So again, restoring us to a more normal volume status in our body. The newest class of agents that have been approved for use in heart failure are an interesting class of agents that were initially developed for treatment of diabetes. They're called SGLT2 inhibitors. And they work on the proximal tubule of the kidney. Now remember, the kidney will filter a lot of urine into the tubular system in the nephron. And in the proximal tubule, there is a transport mechanism where sodium and glucose will be brought back into the body, and as a result, we'll retain more fluid in addition to retaining the glucose. So these inhibitors actually act on that transport mechanism, and by doing so, they allow us to excrete extra glucose and extra sodium and water, and in doing so can also help us adjust our volume status. Initially, these were felt to be primarily useful for diabetics, but there are now multiple studies that show they're also just as useful in non-diabetics, partially because of this renal effect, because it causes a diuresis and a natriuresis, and partially because it seems to have other effects on different areas on the body. It seems to have direct effects on the myocardium, where it reduces oxidative stress and improves the energetics of the individual muscle cells or myocytes. So this has now become an accepted agent as well, and one of the 4 pillars that we use to treat heart failure. And if you look at the most recent clinical guidelines that have been published by the American College of Cardiology, you can see these guidelines pretty well laid out. So in general, we tend to start with the use of an ACE or an ARB in conjunction with a beta blocker. In those patients who have adequate kidney function and don't have high potassium levels, we would add aldosterone or a mineralocorticoid. In those patients, the next step would then be to add an SGLT2 inhibitor to round out our treatment. Now, there's certain niche agents that are used in certain classes of patients. For example, in those patients who are African American or Black, they've been shown to be very sensitive to the use of a combination of hydralazine and isosorbide. Not so in other races and in other groups, but in Black populations they've been shown to be particularly effective, and so that's often another agent we might think of adding for our Black patients. In those patients who have persistent tachycardia, even though there are maximally tolerated doses of beta blockers, ivabradine is another agent that's been used in certain select groups to decrease their heart rate and to blunt that sympathetic discharge that can be deleterious to long-term effects of patients with heart failure. What's important about this is that these effects of these agents are additive, so that if we add an ACE inhibitor or an ARB to a patient's regimen, we can decrease their relative risk of mortality by almost a quarter. If we add a beta blocker to that, we can reduce it by another third. If we add aldosterone, again, we can reduce it by another third. If we switch them from an ACE inhibitor to an ARNI agent, we can reduce it further, and by adding an SGLT2 inhibitor, we can reduce it even further. So we go from a 2-year expected mortality rate of 35% to a 2-year mortality rate of 9%, which is phenomenal, a 74% risk reduction. And in addition, as you can see at the bottom of this slide, we only have to treat 4 patients properly to prevent 1 death, and that's phenomenal. And that's why this is so important. Now, the other problem that we have with congestive heart failure, as all of you know, is one of the reasons we have so many congestive heart failure admissions is because these patients are frequently readmitted, and it becomes a revolving door. They come into the hospital, we treat them, they get compensated, they go home, and then they're readmitted again, and very quickly readmitted, so that nearly 1 in 4 of our patients will come back within the first 30 days for a readmission for congestive heart failure. And there are many reasons for this. It's a problem that a lot of people have tried to attack, and even though a lot of effort has been put into it over the last decade, we've not made a lot of progress in terms of driving those readmission rates down. One reason is that patients in our country don't take their medications as prescribed. If you prescribe a medication for a patient, almost 1/8 of those patients will never fill them. Those who do fill their prescriptions, another 1/8 of them will leave them on the top of the dresser and not take them. And of those people who do take their medications, over a quarter of them won't get their medications refilled at some point, and they'll just stop taking them. And so you actually have patients who you've prescribed medications for, and less than half of them are actually taking their medication on a long-term basis. Now, to help address some of these problems, we've developed here with an internal working group a heart failure clinical pathway. And this was largely spearheaded by Suzanne McGee, and I thank her for all of her efforts. And she and Nikki have worked very hard on this, along with a lot of other people that are too numerous to mention. But the point is that we want to map out a strategy for our patients here in the hospital that not only treats their acute problem of heart failure, but begins laying the groundwork for their continued success after they leave the hospital. So you'll see on day 1, for example, there's a discussion with the patient of what our plans are and what we hope to gain by treating them. We talk to them about their medications, and you'll see at the bottom here the list of medications that we've talked about using, and most of these we've discussed. And we're going to mark off on a day-by-day basis which of these medications they're getting and why or why not are we using them. We're looking at their basic lab values to make sure their kidney function is normal, to make sure they don't have a thyroid problem, to make sure that they're not an occult diabetic. And we're going to get an echo in most cases if they've not had a recent echo, so that we can properly classify them into the category of heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. And this will happen on a day-to-day basis. And in conjunction with that, we're also talking to them about ways to increase their activity level, ways to adjust their diet at home. We've made changes internally to try to adjust our diets to these patients, and in particular, pushing a low-sodium DASH diet and trying to teach them about the benefits of that diet and how they can adhere to that type of a diet at home. Patient education also includes explaining to patients why they're taking these medications, what medications they're taking, what their purpose is, and why they need to continue to take them. Again, to try to improve our long-term patient compliance with medications and to improve our long-term results. And finally, we're working on discharge planning. And discharge planning makes sure that we have a social network for the patient in place, that they have the ability to get the medications that they need, and that we arrange for adequate follow-up, not just in clinics, but in many cases with home health as well. And we're working directly with home health agencies in order to promote a smoother transition from the hospital to the home and from the home to the clinic. Now, that may all seem fairly obvious to you, but there's an interesting study that I saw presented a couple of years ago that was done in Korea, in which inpatients with heart failure, and excluding those with end-stage heart failure, were randomized to either an intervention group or a control group and followed for 6 months. So the intervention group, before they left the hospital, received a one-to-one nursing visit during the hospitalization, and that included getting written material on heart failure, a summary sheet on daily activity monitoring and looking for signals of heart failure exacerbation, a weight and symptom diary. And we are emphasizing in our care plan here not only the importance of weighing, but weighing on the same scale daily and at the same time every day, so we can truly judge whether patients' weights have changed significantly as a reflection of their volume status. And in fact, we've received a partial grant from the American Heart Association, and we've purchased as well on our own scales that can be used in the patient's rooms while they're here, so they can weigh themselves on the same scale every day while they're here, and they can take that scale home with them. So they're looking at comparing apples to apples, not apples to oranges, so that we know exactly what their weight is and how it changes. All of this involves the use of a teach-back method when nursing discusses with the patient. They then went on to have 3 phone calls with the patients at 3, 4, and 8 week intervals to assess self-care adherence and barriers and to reinforce their teaching. Their average inpatient discussion with a patient lasted about 40 minutes, and 60% of these actually had family present for the visit, which was very important because of the social connection with the family and making sure that there's a network for the family at home. The average phone call lasted a little less than 9 minutes, with less family participation, but still significant. And what they found in this study was that heart failure knowledge did not differ in the control group from the baseline to the follow-up 8-week studies. But it improved in the intervention group, which you would expect because we spent more time teaching them about their disease. Secondly, the self-care behavior also didn't differ in the control group from baseline to follow-up, but it did improve in the intervention group. And again, it's because we spent time teaching them and giving them positive reinforcement at intervals along the way. They were also given health care-related quality of life scales, which they could grade their quality of life. And it improved in both, but improved much more in the intervention group. But the bottom line, and what was so important, is that all-cause mortality decreased by 60% in the intervention group over a 6-month interval. And that's phenomenal. And so the reason I'm really here to talk to you today is to tell you what an important role you play in this process, because that's what this is all about, is decreasing mortality in an extremely high-risk mortality group. So I'm going to throw in a few questions here. Some of these are questions based directly on the talk. Some of these are questions that Kathy has been kind enough to share with us that are taken from the CCRN exam. The first question for your response is you have a 76-year-old female who's being treated for worsening heart failure. She's had a poor response to diuretics and nitroglycerin, so her ACE inhibitor dose has been increased. Which of these would be a potential problem you should look for monitoring the patient after this change? A, hypotension due to decreased venous return. B, hypotension due to increased vascular resistance. C, hypotension due to decreased cardiac output. Or D, hypertension due to increased vascular resistance. And we'll wait a couple of minutes for people to respond. So for those of you who answered A, that's the correct answer, hypotension due to decreased venous return. B, we wouldn't expect that we would increase vascular resistance with adding an ACE inhibitor. We would expect to decrease the vascular resistance, so that's not going to be correct. C, we would not expect cardiac output to decrease with adding an ACE inhibitor. If anything, we should increase cardiac output because we have decreased vascular resistance. And then D, of course, would not be right because hypertension would not be expected when we add an ACE inhibitor. The correct answer is A, and that hypotension can occur for multiple reasons, but the main reason is going to be decreased vascular resistance, and because of decreased vascular resistance, there's also going to be less preload to the heart, so decreased venous return. Okay. In this case, we have a patient who's being treated with diuretics and an angiotensin receptor blocker for decompensated heart failure. While administering these kinds of treatments, the nurse should be alert for A, bradycardia, B, decreased urine output, C, hypotension, or D, elevated potassium. And I'll give you a couple of minutes to think about that. So an angiotensin receptor blocker would not be expected to directly affect heart rate, so bradycardia is not going to be our correct answer. We certainly hope it's not going to decrease urine output. The goal here is actually it will increase urine output. It should not elevate the potassium. If anything, the diuretic should cause the potassium to fall. So the correct answer here is going to be C, hypotension, for much as the same reason as the first question. Now, if we added beta blockers to this patient's regimen, we would expect this to A, increase contractility and heart rate, B, decrease oxygen demand and increase heart rate, C, decrease heart rate, contractility, and incidence of ventricular fibrillation, or D, increase the oxygen demand and contractility of the heart. I'll give you a couple of minutes to respond to that. Okay. So beta blockers would not be expected to increase contractility or heart rate, so A is not going to be our right answer. Beta blockers will decrease oxygen demand in the myocardium, but they should not increase heart rate. And the answer D, they should not increase oxygen demand, they should decrease oxygen demand, and they should decrease contractility. So the correct answer is going to be C, because we would expect beta blockers to decrease heart rate, decrease contractility, and to reduce the incidence of ventricular fibrillation by their antiarrhythmic effect as well. So we have a patient that's in the hospital in the ICU who's being treated for heart failure, and they suddenly have the onset of acute pulmonary edema. Which of the following would be an inappropriate nursing action? A, hold the patient scheduled furosemide dose. B, place the patient in Fowler's position. C, administer oxygen by face mask. Or D, administer morphine sulfate 4 milligrams every 4 hours. And I'll give you a minute or two to respond. Okay. So beginning at the bottom, giving morphine sulfate every 4 hours is known to decrease the anxiety of the patient in pulmonary edema, and there's some older studies that have shown there's a beneficial effect to treating acute pulmonary edema that way, so that would be an appropriate action. Giving oxygen by face mask would be an appropriate action because the patient is starved for oxygen, hypoxic, and could use supplemental oxygen. Placing the patient in Fowler's position where they're upright in bed or at least semi-upright in bed has been shown to improve lung expansion and allow the patient to breathe better. But holding the patient's scheduled furosemide dose would probably not be an appropriate action because they're fluid overloaded and we would want to give them their diuretic. So A is the appropriate answer. To follow the volume status of a patient over time, it would be best to have the patient weigh A, once daily, B, every Saturday night, C, every morning after urinating and before eating breakfast, or D, whenever you happen to see a scale. Okay, and I hope most people pick C for that. It's best to weigh at the same time under the same conditions on a daily basis. If not, then weighing once daily is a benefit, but if you weigh on Monday early in the morning before you've had breakfast and you weigh Tuesday in the afternoon after you ate a huge lunch, the weights are not necessarily going to be comparable. So weighing the same time roughly every day and the same conditions is going to give us a better accurate assessment of volume. Weighing once a week is probably not going to be adequate for someone who we're following for congestive heart failure because you really want to know on a day-to-day basis if their weight is increasing by 2 or 3 pounds, so we understand that they're maybe going into early volume overload. And weighing, of course, whenever you happen to see a scale is going to be very random, and we're going to see weights all over the place, and they're not going to be very helpful in terms of managing the patient. So the correct answer here is going to be C. Okay, next question. SGLT2 inhibitors have been proven to be effective in treating patients with A, type 1 diabetes and ketoacidosis, B, acute or chronic heart failure with or without type 2 diabetes, C, diabetes and genital infections, or D, non-diabetics with angina. Make your best choice. Okay. So type 1 diabetes is a contraindication to using SGLT2 inhibitors. They're designed for patients with type 2 diabetes only. And in fact, when used with type 1 diabetics, they can actually be a cause of ketoacidosis. So that would not be a good answer. They have been proven to be effective in acute or chronic heart failure, either with or without type 2 diabetes. So normal patients as well as diabetics can benefit from that. So the correct answer is going to be B. C, I brought up diabetes and genital infections. One of the potential side effects of SGLT2 inhibitors can be the development of genital infections in diabetics. That's something we always need to look for when we treat with these agents. So obviously, if they had a genital infection, we wouldn't necessarily want to start them on an agent that's going to make that worse. And D would be incorrect because there's been no proven benefit for treatment of angina with these agents. Okay. Last question. Guideline-directed medical therapy for heart failure involves using multiple agents because A, complex regimens improve patient compliance, B, this reduces the number of potential side effects which can occur, C, prescribing more medications makes it more likely that the patient will take some of them. Or D, the benefits of reducing mortality of the recommended drugs are additive rather than overlapping. Okay, so A is not going to be correct. Obviously, the more complex we make a regimen for a patient, the less likely they'll be able to comply with it, even with good teaching. So that's not the purpose for using multiple agents. Second answer is also not correct because each of these agents can have potential side effects, and the fact that we're using more agents exposes patients to a larger array of potential side effects because each agent has its own. C is also not a correct answer because there's no indication that just by giving them more prescriptions that they're actually going to take more medication. But the answer is D, that the benefits of reducing mortality of the recommended drugs are additive rather than overlapping, and that's why we can achieve, by using a multi-pharmaceutical approach, as much as a 76% reduction in mortality rates over 2 years. Okay. Well, I'm going to complete our formal talk here, and we're going to open it up to any questions that you might have. I know it's a very complex topic, and it's one that we could speak about for hours, but we've tried to begin with a bare bones and an overview of the problem, and also to tell you how excited we are about our opportunities that we have to impact the mortality and the health of our patients by doing a more consistent job of treating them appropriately and working with them in the education end before discharge to make sure they understand their regimens and understand the rationale and need for medical adherence. Well, I thank you all for joining us today. If you do have any questions, feel free to flag me down and be happy to try to help. And thanks again for your help.